What are we going to need to do to stop Delta?
Well, I think that Delta, at least as we've seen it over the last 4 to 6 months, is in some ways going to stop itself. And what I mean by that is that one of two things will happen. One is the surges that we see that rise very quickly in case numbers and drop rather precipitously. If that is the pattern, the question will be, will they continue over and over again in the same countries? Maybe, maybe not. The second thing, though, is that unless it's replaced by a more infectious variant, which would even be a greater challenge, eventually it's going to affect enough people that we will start to see, with protection afforded by having been infected, a reduced number of people that are susceptible to the virus. So either way, it can't continue to do what it's doing, on and on. The question is, how long is it going to do what it's doing, and under what conditions will that occur?
So we talked a little bit about the virus. What about the humans, the human behavior in response to the virus? How does that need to change?
Well, I think there are actually two kinds of people right now that can generally be categorized, and those that will do whatever it takes from a public health perspective to reduce, if not try to eliminate, their risk of becoming infected. Vaccination is good. They will also take the steps to distance themselves from others, etc. Then there are those who basically don't have access to the vaccine, so it's not that they wouldn't take it, or they have access to the vaccine but won't take it. And I think that under those conditions, the virus will eventually affect most of them as cases of infection. And this is one you can't wait out the clock on. If I haven't been infected so far, I might say, well, I'm not going to get infected, I'll just wait it out. This virus is infectious enough, it will find you eventually. If it's not this surge or the next surge or the surge after that, it will find you. And I think that in that regard, that's why ultimately we will see most people, whether they are trying not to get infected or they don't care if they get infected, meaning they don't believe it's real or they're not going to take the measures to avoid infection, they will know ultimately a COVID-related outcome.
Bit of a devil's advocate question, but are the vaccines working?
Well, the challenge in answering that question is working. And what I mean by that is it's all about expectations. We set up a global expectation after the first mRNA vaccine studies were done that you got a vaccine that's 90 to 95% effective. And I think that was a mistake. We had to, I think, consider the possibility that over time there might be waning immunity. We had no way of knowing that with the initial data sets that came in. Just by the very nature, it had only been 3 to 4 months and 5 months in some cases where we had data on longevity. Now we're beginning to see that, in fact, the time after immunization may have some role in how protected you are. The second thing is we had to consider the variants. These variants are very different. And this is not our grandmother's variant that we had a year ago. As serious as it was even then, this is a whole different ballgame. And so I think that now we're dealing with a much more highly infectious virus. I think it's unclear yet is whether it's causing more serious illness. And it's also unclear whether or not it's evading any kind of immune protection. But these are the things we're going to be learning over the course of the next 3 to 4 months, just how to each of these contribute to potentially a reduced prevention or protection with the vaccines. And we have to anticipate that now.
So older people were identified as being more vulnerable to getting a severe illness from COVID, and they were prioritized for getting the vaccine. We also know that older people don't mount as strong as robust an immune response to the vaccines as younger people. So do you think that we may be getting some skewed data in terms of efficacy in the first crop of people vaccinated, partly because it may be waning immunity from the vaccine, but also because those people may not have mounted typically robust immune response?
Well, I think there were enough people even early on that were relatively healthy that, were under age 65 that will give us some sense of that vulnerability you're talking about. But I think it's important to understand that over the course of the next 3 to 4 months, we're going to be simultaneously looking at the interaction of which kind of vaccine you received How long after the time period was it that you have been followed up and therefore would have some sense of latent immunity? What is your underlying health status such that could that contribute to a reduction in protection? And also, really, finally, it's all about the issue of what vaccine may change with each variant. And, we have not really yet identified a unique role that the Delta would play beyond that of being much more infectious, but maybe it's possible that that could be the case. And then we'll want to look at that relative to the vaccines that we have.
So do you think, we know that Delta is capable of replicating, really quickly after you're exposed to the virus and you get infected? The incubation period seems to be hastened, and it seems that it's capable of replicating at really high viral loads. Do you think that that is, down the track going to ideally require vaccines that can induce much stronger mucosal immunity, better IgA, things like that?
Well, clearly it's one possibility that we're going to need to look at vaccines that also give good protection against viral replication in the upper respiratory tract as well as the lower respiratory tract. But again, I think it's a little bit too early to say that. That's surely one area that we need to examine very closely. I think the most important message I could share right now is the need for great humility and acknowledging that there are many questions that we still don't have answers for that we need to, and this being one of them. I think the one area, though, that I also would lay out there, even in that context of humility, is we have no new data at all supporting that there are safety signals with these vaccines. We've pretty much exhausted those with the millions and millions of people who have gone now through 4 to 6 months of having been vaccinated. And so as we have this discussion, it's really important for us to share with the public, yes, get vaccinated. This is not a safety issue. We are still working out the mechanics of how best to use these vaccines for maximum protection. But they do afford great protection, particularly against death. And they are the same vaccine issues now that we've ever had. And we've demonstrated convincingly that the risk of having an adverse outcome from the vaccine is far, far, far lower for the very same kinds of concerns than it would be to get the disease itself. So at this point, yes, we're going to have a need for a really robust evaluation of these vaccines, looking at all these different factors, but at the same time, not hesitating for a moment to keep pressure on getting the vaccines out and in people's arms.
Yeah, do you think that the fact that we are seeing more evidence that when you're vaccinated, you are still at risk of being infected, and that infection that you have may be transmitted to other people? At the start of this whole pandemic, I don't think anyone thought that sterilizing immunity was a possibility. Then we got these amazing results from the mRNA vaccines, and it's like, whoa, maybe there is some degree of potential for sterilizing immunity. Delta, I think, has pulled that rug from under our feet. But do you think that there may still be ways in which we can improve vaccines to get some ability to produce a sterilizing immune response?
Well, I think, first of all, we have to look at how the vaccines are performing. And if there is substandard performance, why? What is it about the vaccine? What is it about our immune response? What is it about the virus variant? All those things have to be considered so that we just don't have a scattered approach to trying to get a better vaccine. Let's target what the challenges are and go for those. And if that doesn't work, then look at other potential ways to improve vaccine performance. But I think the most important message right now is that we will be doing this. And this is important. This is not a mistake. It's not a problem in the sense of why didn't we, take care of this sooner? This is what corrected science is all about. Corrected science is constantly a process where you learn, you implement it into what you found. You make recommendations. You do more work, you learn. You incorporate it into what you found. You then basically make recommendations. And I think that what we've not done a good job of is letting the public know that this is going to be a process here. We didn't have 4 or 5 years of research vaccinating a small number of people for some time and letting Mother Nature, in a sense, do an experiment over the next 4 to 5 years to see how people responded. That doesn't mean that we took any shortcuts with safety. We know we have good safety data, but we're going to be learning things about these vaccines relative to both time, the individuals who are vaccinated, and the variants themselves, and what role they may play in how we deal with these vaccines and prevention.
Yeah, I think that's a really helpful message too, because I think that some people, I get the impression in the US are quite angry that the advice keeps getting changed, and they get told that they don't need a mask anymore, and now they're being told that they should be wearing a mask. So they're like, why are you keeping changing the story? And it's because the evidence evolves.
That's corrected science, and I think that's what we need to really help illustrate to people. You want that. You want to find out what it is you need to do to improve in the process. I mean, if we didn't do that, we'd still be using walkie-talkies for cell phones. And I think that that's an important message is, we learn, we get better. We learn, we get better. We learn, we get better. And that's where we're at right now. And that doesn't mean that anything to date has been mishandled or that it has not taken into account things it should have. It means that we're experiencing these vaccines live and real. And again, as long as the safety features are not a challenge, keep using them, putting them out there, and then learning how to better use them. And that may be including finding additional new ways to do vaccinations. So all of it's on the table.
Yeah, and I think too, the situation is dynamic. We had Alpha back at the start of the year. Now we've got Delta, and the landscape is not staying stagnant. It's changing. The challenges.
That's where I think it's really important to have that element of humility. I've said for some time, and you've heard me say this, is, we're not driving this tiger, we're riding it. And vaccines have surely played a key role in how we ride it, meaning that if you look at the data around the world, where we have highly vaccinated countries, we are seeing major reductions in deaths. Sure, we're seeing an increasing number of breakthrough infections. We still are seeing, in many instances, increased hospitalizations. But overall, we're having a tremendous impact with these vaccines. Our challenge is going to be how to continue to use these vaccines to maximize the most important aspect of public health, preventing infections. If you can't do that, preventing serious disease, and then most of all, of course, preventing death.
Yeah, I think that the message got distorted in the sense of, can we vaccinate our way out of the pandemic? That was a whole lot more nuanced. That vaccines, play a key role in immunizing people and providing that level of protection. Yeah. But ultimately, it's human behavior.
Well, I think also it reflected a certain amount of high-income country elitism. We can get ourselves vaccinated out of this pandemic without really ever considering what would that mean for the 6.4 billion people who live in low and middle-income countries. A pandemic's a pandemic. It's a worldwide epidemic that will continue until you take care of it around the world. And we realize from a humanitarian standpoint that's obviously critical. But if even that doesn't move you, the very fact that the strategic protection of our vaccines means we don't have unfettered transmission in low and middle income countries that could spin out new variants. And so it's going to be very important that we understand why we have to get vaccine to the world. And, we never really talked about that. Everybody focused on how could we get high income country vaccinations done. And, as much as COVAX was an attempt to help move vaccines to these low and middle income countries, we've not done a good job. And this pandemic won't be over until it's over in the world. And I say that because even though we may be protected largely by our vaccines, all we need is one variant that ends up challenging the immune protection from those vaccines. And it's kind of deja vu all over again.
And look, we've seen variants come out of Kent in England, and I'm not dismissing the fact that we could get a variant come out of Austin, Texas, or Tallahassee,
absolutely
Florida.
Could. I think right now, if you look at what's happening in many high-income countries, we surely are challenged. We are at risk. But if you wanted to look at what really is the risk, It's looking at the 6.4 billion people in low and middle income countries. Kind of for every throw at the genetic roulette table that we have in a high income country, we have thousands of throws in the low and middle income countries. And ultimately, it's a matter of chance. And that's what we have to understand. We're playing genetic roulette with this virus, and it's just going to be a matter of time before we will see changes in the virus. And our job is going to be anticipating what those changes might be and having the vaccines that work for that particular variant.
It's kind of a political versus or a humanitarian versus virological or immunological debate about boosters. Where do you sit on that? Should we be giving boosters in Israel and countries like that, or should we be focusing our attention ensuring that everyone in the low and middle income countries has a sniff of a vaccine?
Well, first of all, we have to distinguish between completing a prime series and a booster. For example, in the United States today, where we're seeing the approval process of additional third doses for those who have underlying immune deficiencies, I don't consider that a booster. They never did reach a satisfactory level of protection. So this is really continuing the prime, just as we would if we had a 3 or 4 dose childhood immunization process. A booster occurs when you've been vaccinated, you have basically met a level of immune protection, and then over time it wanes. And so I think it's important just to distinguish those two, because we may find that there are others who also will need more than 2 doses that would be considered part of the prime and not part of some kind of a booster situation. But I think the booster issue is a really very, very difficult one. I understand that. I get it, because I am worried about what's going to happen in low and middle income countries, surely from a humanitarian standpoint, but also from the strategic protection of our vaccines in high income countries. And so we need a much better approach to this. I actually support what the WHO came forward with in terms of calling for a moratorium, for at least to discuss this. What are we doing? And I think at this point, I've not yet seen what I consider to be the Manhattan Project mindset to get us many, many billions of doses of vaccine over the course of the next 1 to 2 years, as much as, we're going to do better. Well, right now, doing better is not good enough. And so I think we really do have an urgency in terms of vaccine manufacturing. Then we also have an urgency in what I would call basically a whole series of Marshall plans. It's not enough, as we've learned in the United States, to have vaccine where you need it. Can you get that needle in the arm, that last inch? And I think that's going to be a challenge globally too, not just in the United States, not just in certain countries in Europe. And so we also have to have a major initiative put in place to be certain culturally sensitive education, information for whatever country you're dealing with is available and helps move these vaccines from a vaccine to a vaccination.
Awesome. Is there anything else, sir, that you want to mention on the whole?
Oh, you're always so damn good. You didn't need me. You could just record yourself.
No. You're awesome. And your perspective on the booster or the third shot in people who really didn't mount a significant response to the first or even second dose, I think is a really valid and important point.
Yeah.
So thank you for that.
Obviously they're using up doses, but at the same time, they're not asking for the luxury of a booster. They're just saying, just first time out, can I get, and we have the data showing that with third doses, you actually can begin to achieve a modicum of immune protection.
And our good friend Shane Crotty at La Jolla and others have shown that that if you do need a third dose, in many instances, you may be able to mount a pretty good immune response to a quarter of the antigen.
That's right. Yes, absolutely. Yeah. His work is so important. It's really good work.